Hello, my name is Arya Javidan, and I'm the Program Coordinator for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series, Digital Health in Homes and Communities, Emerging Opportunities for Patient Engagement. Today's webinar is hosted by the Great Plains Telehealth Resource and Assistance Center, gpTRAC. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs, and they are presented on the third Thursday of each month. Just to provide some background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask any questions. Questions will be answered at the end of the presentation. Please note that closed captioning is available for today's webinar and is located at the bottom of your screen. Today's webinar is being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. And with that, I will pass it over to the Director of gpTRAC, Jonathan Neufeld.
Great, thank you, Arya. If you can stop sharing, then I can share. All right. Just a few too many clicks here. So I just wanted to welcome you all as well, and I'll be introducing George in just a minute. I will highlight the fact that we are the Great Plains Telehealth Resource and Assistance Center. We're in that north central region of the country, and like all the TRCs, we provide technical assistance and training for organizations of all kinds trying to develop and sustain and build telehealth programs. And we would love to hear from you, as well as any of us in the consortium would love to hear from you to help out with your telehealth efforts. I just also want to highlight something for you. We, the Great Plains Telehealth Resource and Assistance Center, will be hosting our annual conference, first time in 3 years. We are eager to be back. Fingers crossed that that we can do this safely. We are going to be implementing a lot of safety protocols to make sure that this is a safe conference. But you can get some information about this. It's going to be at the Radisson Blu in Minneapolis on May 23rd to 25th. The main conference is 24th and 25th, and you can find out more at gpTRAC.org/conference. And now I want to introduce Dr. Demiris. Dr. George Demiris is the Penn Integrates Knowledge University professor at the University of Pennsylvania, and he holds joint faculty appointments in the School of Nursing, Department of Biobehavioral Health Sciences, and the Informatics Division of the Department of Biostatistics, Epidemiology, and Informatics at the Perelman School of Medicine. He directs the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, and is co-director of the Penn Community Collaboratory for Co-Creation. In his work, Dr. Demiris explores innovative ways to utilize technology to support older adults and their families in various settings, including home and hospice care. And he also focuses on designing and evaluating personal health systems that produce patient-generated data, including smart home solutions for aging. I'll just also point out that Dr. Demiris is going to be our keynote speaker at the gpTRAC conference. So we hope that you will listen to him today and benefit, and also come back around and join us in Minneapolis for his keynote address there, where we hope that he will expand on some of the ideas that he is going to provide us today. With that, I will welcome you, Dr. Demiris, and turn it over to you.
Thank you so much. Thank you for the invitation to be with you today and for the great introduction. Let me share my screen. So again, thank you. It's great to be with you. I'm going to talk today about digital health in homes and communities and highlight some of the opportunities as well as potentially challenges that arise when we think about new ways to facilitate patient engagement. So all this work fits within this framework of precision medicine or precision health that we often talk about, because it calls for collecting and analyzing large data that take into consideration the unique individual patient's behavior, lifestyle, genetics, and environmental context. So it calls for an assessment that goes beyond the just episodic clinical assessment we see during a clinical encounter, and calls for new tools and techniques to better understand what's going on with people's lives and behaviors in the homes and communities where they find themselves. And in that concept, we often talk also about opportunities for digital phenotyping, namely the moment-by-moment quantification of that individual level human phenotype in situ using data from personal digital devices such as wearables. And just like the ecological momentary assessment, which is a technique whereby we try to capture what's going on with somebody we observe at that moment in time in a real world setting. Similarly, with digital phenotyping, we're looking at using tools to understand how people's behaviors and their physiological or other variables may change at any point in time outside the clinical observation space. So we have many opportunities with digital health to facilitate behavioral sensing, and usually that is based on passive monitoring and wearable technologies. The goal with all these tools would be to objectively, remotely, and continuously measure aspects of patient physiology, behavior, and symptoms. And the advantage here is that we can understand what's going on with an individual in their own home or in their own community and capture behavior and activities of daily living without needing human observers and not having to rely on self-report. And as we know already from the literature, self-report has a lot of limitations because of recall bias, the tendency to over or under-report, and also the cost that comes with trying to validate and use observers for validation of those reports. The behavioral sensing tools can allow us to shift from episodic to continuous monitoring and assess people in the real world where they find themselves and not in a laboratory or artificial environment. The goal when we think about these digital tools is obviously not for somebody to be at the other end watching those data points come in real time, but rather to develop sophisticated algorithms so we can identify events and trends or patterns in the data that would show that perhaps more attention is needed or a certain trajectory is leading to undesirable implications and could be addressed earlier. So actively promoting a more proactive rather than a reactive model to the observations that are made through passive sensing. And speaking of sensors in the home, there's a lot of discussions around smart homes, and that is one great example of passive sensing that could give us insights into people's daily living. A smart home is broadly defined as a residence with embedded technology that facilitates passive monitoring of the residents to enhance their safety, independence, and well-being. And this was a term that originally in the 80s was used mostly for energy efficient buildings, but soon in the 90s, it became clear that a lot of these technologies could also be used for health-related purposes. With the emergence of Internet of Things devices, we now see a lot of smart home applications that are commercially available for entertainment, security, and can also serve health-related purposes. We've done a lot of research here at the University of Pennsylvania looking at smart homes, and we've tried to look at even commercially available sensors to see how they could specifically support older adults as they wish to age in place, namely stay at the residence of their choice for as long as possible, rather than changing settings of residence every time people's healthcare needs change. So we've been specifically looking at community dwelling older adults, 65 years or older, who live independently in their own home, a retirement community, or even an assisted living facility. And we've been doing some research to understand what type of sensors people would be willing to have installed in their homes, and also how they would share data that are resulting from these sensors with trusted others. In our studies, we give people options between door and window sensors that basically capture door and window activity tracking and can give you an idea of how much time people are spending inside the home versus outside the home, how much they're moving in the home, using things like motion sensors to track overall mobility and potential sedentary behavior, but also environmental sensors that capture temperature, humidity, and luminosity. All this sensor data can be used to make inferences about activities of daily living, how much time people are spending in bed, how much are they engaging in meal preparation or hygiene, or being sedentary or being more active inside or outside the home, and even inferences about overall potential social isolation and loneliness. So the advantage with a lot of these smart home solutions is that you don't have to do an extensive retrofitting of the home, and you can easily install these sensors in the existing infrastructure. And the passive sensing solution has the advantage that it works passively, which means that you don't have to train users in operating new hardware or software, which can be a benefit, especially when you have people who may be dealing with multiple chronic conditions or might be experiencing some cognitive limitations and may not be ready or willing to operate any type of new hardware or software. And once you have the infrastructure in place, you can easily replace individual sensors when more advanced technologies become available. And in our studies, we do give people the choice as to what types of technologies they want to have installed. And oftentimes people who are with us for a year or two might change their mind and say, you know, I really want a motion sensor after all, so we would just add the sensor later on. And we're trying to avoid cameras or face recognition technologies to choose sensors that would have more privacy preserving approaches in terms of the data collection. And those sensor firings are stored in a server de-identified from the individual. But obviously privacy can become an important consideration when we think about these types of digital tools. And I'll talk about that later as well. So in my presentation, in the title, I talked about patient engagement, and this can be a challenge when we think about passive monitoring. How do we find ways to engage users so that they can actually make sense of their data and find purposefulness and utility in these types of smart home data? In our work, we're trying to develop different types of dashboards for residents and their family members or trusted others to be able to review the data that's collected from the smart homes. But the challenge here is to create actionable information, not just descriptive data about how much time they spend inside the home versus outside the home, but rather, what does this mean for overall social engagement and those trajectories over time? How much I'm moving and I'm on my feet every day, and whether this is increasing or declining over time. Am I becoming less or more restless at night? How much time am I engaged in preparing meals or spending in the kitchen, and so forth? And the goal is for these systems to generate alerts when an adverse event also has occurred. So in addition to looking at the trajectories and saying, oh, it looks like I'm becoming less active, it's also important to know if the sensors indicate that it looks like I have fallen and I'm not moving, or I left my apartment and left the door open and didn't return. So there are specific alerts we can define so that we have trusted others be notified when such an alert occurs. As we think about visualizing smart home data to facilitate patient engagement, we have to recognize that we're dealing with various stakeholders. We're having older adults with different information needs and preferences, different levels of experience with computer technologies, family members and clinicians, and even administrators in retirement communities. And they all have different information needs and purposes of use. A lot of our older adult participants want to use these dashboards to actually annotate daily events and provide a lot of information with granularity that may be of less interest to a clinician who's more interested in longitudinal observations. Similarly, family members are sometimes interested in more detail than, let's say, the administrator of a retirement community who is more interested in aggregate data about overall trends in their community. The goal is to support efficient and effortless extraction of information that's important pertaining to events, trends, and patterns in the data. We use a lot of density maps for the sensor activity, and here are some examples of those types of sensor maps. If you look at the lower part of the slide, you can see two different density maps of the same resident 1 year apart. So a density map basically shows on the x-axis the hours in the day, and the y-axis are the days in the month. And what you see is the amount of motion inside the home based on the motion sensor firings per hour. So you have the whole spectrum, black meaning time outside the home, the resident is not inside the home, white meaning the person is in the home but there's no movement, and then ranging from gray all the way to dark blue is the level of mobility. So dark blue means there's a lot of motion happening during that hour segment. So on the left side, you can see in this density map, a resident who tends to show very little motion activity in the early hours. So that's because they're in bed. So usually they sleep from about 9 p.m. to usually 6 a.m. They're pretty standard or consistent in terms of waking up around 6 a.m. and there's some motion in the apartment until about 8 a.m. where most days they leave the apartment for about an hour to have breakfast. They come back, there's a little bit of motion, they leave the apartment again around noon, usually for lunch, they come back, and then they leave around 6 p.m. consistently for dinner and come back. Now, this is the same resident a year later on the right, and here you can see their density map being completely unpredictable and definitely less consistent. You have a lot of motion even at night. Even in one instance, you have at midnight the resident leaving their apartment for 1 hour. You see that they're skipping most lunch and breakfast. Their sleep quality has definitely changed from a year before, but they're somewhat consistent in their dinner in that they spend time between 6 and 7 again in the community having dinner in the dining area. These are the real data from a resident whose actual vital signs like their blood pressure and their glucose levels didn't change from 1 year to the next. So the community nurse visit that happens every 6 months didn't indicate any alarming data or trends. But the same resident, when you look at their density map, shows that clearly something else might be going on, even though the community members didn't necessarily notice them being absent as they were pretty regular with their dinner. And that's a person who was experiencing some early stages of cognitive decline. And that manifested itself earlier in the density map in this type of visualization, information that we can extract from daily living and perhaps give us insight before a catastrophic event occurs. Another typical example of the value of smart homes that has been demonstrated in literature has to do with urinary tract infections, where you can very easily see a sudden increase in bathroom visits at night. And you could see that difference early on so that you could interfere before a hospitalization becomes necessary. I wanted to also briefly talk about another initiative we have at the University of Pennsylvania looking at smart home technologies, but here we're looking specifically at fall prevention. We've started an initiative we call Sense for Safety, which is a technology-enhanced fall risk assessment and fall prevention nursing intervention for socially vulnerable older adults with mild cognitive impairment. And here we're trying to specifically look not at just fall detection, but actually fall prevention. We're focusing on falls because it's such an important and critical issue for older adults. And mild cognitive impairment and housing conditions are each independent risk factors for multiple falls. As a matter of fact, cognitive impairment is the leading risk factor for falls in older adults. And over 60% of older adults with mild cognitive impairment will fall annually 2 to 3 times the rate of those without cognitive impairment. And on top of that, socially vulnerable older adults are at higher risk. older adults living in low-resource neighborhoods with poor housing conditions have twice the risk of falling. We were thinking about creating a solution that uses digital tools like smart home features that could actually keep people safe before the fall occurs, if at all possible, and specifically targeting older adults with mild cognitive impairment who live in low-resource neighborhoods. So with Sense for Safety, we're looking at technology again, and we're using depth sensors, and I'll talk about them in a minute, but we're installing depth sensors to use information about people's gait characteristics and link the older adult with a nurse telecoach who guides them in implementing evidence-based individual plans to reduce fall risk. The idea is we are able to identify escalating risks for falls real time through this monitoring, and we can employ machine learning to inform individualized plans to reduce fall risk. The depth sensor is basically using silhouette extractions. So you don't actually see a video of the individual, but rather their silhouette extraction. That video itself is not get permanently stored. Instead, the depth sensor allows us to extract information about gait characteristics, such as stride length and gait speed, walking speed, that are important for calculating fall risk. So all we ultimately end up saving, if you will, or storing is fall risk scores for these individuals based on their gait characteristics, not the actual silhouette extraction videos. The silhouette extraction videos can be used for a fall alert if the nurse or the trusted other wants to confirm that it's not a false positive, so they can see the last 10 seconds up to what was classified as a fall event. So our nurse coach can access this dashboard and look at the information that's generated by the depth sensors. The stride length, average speed, stride time, all are used to calculate a certain fall risk score. And we're working with engineers at the University of Missouri who have been working with depth sensors for a while now to use their formulas for fall risk calculation and fall risk prediction. Our nurse coach can then annotate this dashboard by entering additional information that has to do with medication information or hospitalization information that's important in order to have a more complete picture as to what's going on with that person in their lives. And then the coaching sessions can use the information about fall risk changes to inform educational or exercise interventions, and people can then have more tailored behavioral or educational or other interventions based on their own ever-evolving fall risk profile. When we think about smart home technologies and in general digital tools in the home, one of the challenges becomes how obtrusive these technologies may be. And that's not only about privacy, although privacy is definitely an important aspect and consideration in that. So we use the term obtrusiveness that we define as a summary evaluation by the user based on characteristics or effects associated with the technology that are perceived as undesirable and physically or psychologically prominent. In other words, it's basically the subjective assessment by the individual as to whether they are willing to tolerate, appreciate, or reject certain features of the smart home. And that's especially important when we think about technologies that we introduced in one of the most sacred spaces, it's one's own private residence. So within that obtrusiveness definition, we developed an obtrusiveness framework to better understand what could be all those different dimensions that ultimately affect one's subjective assessment of the technology. And those have to do with the physical dimension of the technology. How does the technology get installed? Does it cause obstruction or impediment in the space, or maybe aesthetically it's not aligned with the home? Do you have cables hanging from the ceiling? Do you have big boxes that you have to install in your living room? And then for those who have to operate any parts of this technology, whether it's a dashboard and it's more of a software solution, or even perhaps actually deal with the hardware sensors, what are the usability dimensions? Are those systems easy and accessible, easy to use and user-friendly, and do they place additional demands on time and effort? Privacy is one of the core dimensions of obtrusiveness, and we have to think about invasion of personal information and violation of the personal space of home. Here we need to think not only about the technical specifications, have we encrypted the data, is the server password protected, which are very important considerations, but we also have to understand what are the needs and preferences of the individual residents. And do they really fully understand what they're signing up for? Even if the technology is not perhaps violating somebody's privacy, if people feel that they are living in an environment that might be intruding into their own privacy sphere, that is a problem, whether technically it's addressed or not. Another dimension has to do with the function of these digital tools. Are they performing as planned? Are they reliable and valid? Or are they perhaps inaccurate or restricting in how they operate, or perceived as not really accurate or useful? Some systems work better when people are homebound, may not work as well when people are moving around the community. So we have to think about the function aspect of the technology. A key element in a lot of these digital tools is how they may interfere with the existing relationships and ultimately the human interaction dimension. Do these digital tools introduce a threat to replace in-person visits? Could there be a lack of human response in emergencies? And what effect would the technologies have on relationships? One of the concerns that several of our participants in smart home studies have raised has to do with people thinking, if my loved one or family member can log in remotely to a portal and look at the dashboard and see that I'm doing okay, does this mean they're going to call less often or maybe come and visit me less often? Does it mean the community nurse is not going to come as often as she used to because they can check on me remotely? And what does that mean for these relationships that are either ongoing or new relationships in a retirement community, for example? Another dimension has to do with self-concept and what the technology may mean in terms of having all that installed in your home, and whether it represents a loss of independence or could be a cause of embarrassment or stigma. This was something that has been found over and over again in literature with some of the older fall detection wearable bracelets, where people were refusing to wear them because they thought they could be stigmatizing. If I'm the only one in the community wearing a fall alert, does this mean I'm the most frail and in need of assistance? And similarly with smart homes, when we first started conducting smart home studies, long before it became more accessible through internet providers and safety and entertainment packages, the original idea of having sensors in the home was concerning to some participants. And we would have participants saying, I will sign up for this only if I'm not the only one in the building who does, or only if my other neighbors also sign up for this. What does having these digital tools in the home mean in terms of the daily routines and how the technology may or may not interfere with daily activities, and whether it requires that users acquire new rituals? And then ultimately concerns about the sustainability of the technology. Am I learning to depend on a technology that I might not be able to afford in the future, or that I might not be able to operate in the future? And how will my future needs change? And will I still be able to accommodate the use of the technology in the near future? All of those are diverse set of considerations that deal with a lot of different aspects, but they all fit in that framework of obtrusiveness and highlight that when we think about smart homes or passive monitoring tools, it's not just about the amount of training that those tools may require, but there's a lot of other underlying factors that should be assessed. So rather than saying a smart home solution is in the background and doesn't really interfere with anything, we have to think about what the specific implications are for the person living in that home, as well as their own set of connections, their personal and social network. When we think about these digital tools for patient engagement, there are research policy implications, but also clinical, practical, and consumer education considerations. And I want to briefly touch on all of those categories. When we think about research, a lot of the smart home research right now is focusing mostly on feasibility work. Can we really install the technology? Will this be acceptable and accessible to older adults and their families? But we definitely need more evidence, even though these studies may be difficult to carry out, in terms of the long-term impact of a smart home solution, for example, on health outcomes, cost, and efficiency. Can we really use these types of smart home solutions to, let's say, reduce rehospitalizations or keep people safer and with high quality of life in their own home? Sometimes this design that those studies require can be difficult because of the time and the resources necessary. For example, it's really hard to do a clinical trial where people are randomized to smart homes or non-smart homes. But we do need more evidence and more longitudinal data to have a better understanding of the impact of those types of platforms on patient outcomes, but also on things like patient engagement and shared decision-making. We know that people want to access their data and have a say for the most part, and our participants become more engaged and aware of their own daily living once they get to access these dashboards. But what does this really mean in terms of the quality of care they receive? A lot of times we hypothesize that smart home research would lead to new models of patient-centered care delivery because people can be more actively involved in their own care. But we still need more research as to what that really means in terms of patient behaviors and also diagnostic and treatment-related decisions. How does the smart home solution affect healthcare utilization? Is it that people are being kept safe at home and therefore they are utilizing healthcare services less? Or is it that because the system monitors those trajectories and alerts at an earlier point when something is wrong, it actually leads to an increased utilization? What's the accuracy and reliability of data in various settings? How can data be standardized? And then ultimately, how do we visualize and communicate that data? I already showed you some of our dashboards as well as our density maps, but there's a lot of other complex questions around visualizing data in a way that's meaningful and actionable. The smart home data should not be only available to researchers and clinicians, but they need to be not only available, but accessible and actionable for the general users to actually make use of them. And that, I think, still becomes a great challenge when we deal with a very broad range of users when it comes to their computer experience with different systems, cognitive and functional abilities. As we think about introducing new digital tools in the homes and the communities, there's clearly concerns around interoperability and whether these systems would talk to each other. And I know that speaking to a group that's quite familiar with telehealth, you know that interoperability is not a new concept when it comes to thinking of new digital tools. And some of the same challenges that we see with home telehealth apply to smart homes too. How can we think about interoperability, but also standards around tracking modalities? And issues around liability, who is to be liable and accountable for all the data that are collected outside of the clinical setting, and if information were to be extracted from smart home data but was not acted upon, who would be in charge of that? What are the privacy policies for those different sensor solutions? And ultimately, as we see more evidence, if we do get to see more evidence of a lot of these systems, what would be the reimbursement structures and what could be the potential models for those digital tools to be easily integrated into existing models of care or potentially introduce new models of care. There are implications for the clinical workforce. How do we integrate these types of tools into the clinical workflow? And how do we create systems that help with interpreting data without burdening clinicians? Who would be shifting through those large quantities of data? And what is the burden and fatigue that may be introduced through real-time alert systems? How can we refine our algorithms so that we don't actually need people to be shifting through the data, but rather responding only to pieces of information that have been extracted from this large body of data? And what are the responsibilities to review the data, and how can those be delegated? And then also clinicians need guidance as to how to identify which tools to recommend to their patients for those patients who want to become more actively involved. And we now see that more in gerontology, where patients might be asking not only what type of wearable should I get in terms of a fitness tracker, but are there available solutions for sleep monitoring that I could use, and are those accessible and clinically meaningful? What about solutions for activity tracking, sleep quality, energy expenditure, things that perhaps people were not necessarily familiar with before, or we didn't have that many commercially available options? But how do you navigate that complex landscape? And as a clinician, how could you help your patients identify the right tools if they wanted to use these tools? And that also brings us to consumer education, because there are specific implications for any of us as a patient and or health consumer. How can we select accurate and reliable tools? There are already many commercially available smart home solutions and sensor systems. There's obviously a lot of wearables too. How would we know which of those to choose from and would be the most appropriate for whatever it is we're trying to monitor? And how we can interpret data. We need to discuss and understand expectations and what the role of these digital tools may be in terms of health monitoring. Another big concern is that we're trying to create these new innovative systems to increase access, but it might be at the same time, as an unintended consequence, a way to exacerbate existing disparities. For example, when we think about smart home solutions, a lot of those require broadband internet availability. So people who may already have access to healthcare resources may just be enjoying additional tools, but people who are already perhaps left out of specific spaces would then be further excluded with systems that exacerbate those disparities. So how can we think about inclusive design for telehealth and inclusive design for smart home systems, or in general, inclusive design for digital health tools? When we show our participants what sensors collect, and we describe the sensors, it becomes really clear that people have very different levels of experience with previous technologies, and some participants can make a lot of sense of our graphs and data, and some others cannot. We have to think about health literacy, digital literacy, and data literacy. Data literacy has to do with users understanding the use of their data, what gets stored and who has access, and is a complex factor to address. It's not only how can people make sense of their data and what is their ability to process graphs or other information that summarizes their data, but also understand aspects of data access. For those of us who do research in this space, sometimes we develop these consent forms where we have to think about how to use lay language to explain complex terms like the cloud or how data are transmitted wirelessly and so forth. And we put in a lot of effort to try to make this material accessible. And we use the teach-back method where we tell our participants what it is they're signing up for, and then we're asking them to reiterate what their understanding is of what they're signing up for. So these consenting visits take a long time, and we've developed education protocols to achieve our goals for consenting and to make sure that participants understand what they're signing up for. And in spite of all these efforts, we often do get people who a few weeks later will look at their dashboard and it will indicate that they had, let's say, a week where they didn't spend much time outside the home. And they'll say, how did you get that information? How do you know that I didn't have an active week? Even though they had signed up for the smart home sensor study and we went through this elaborate consenting process. So it's obviously something that becomes very clear. It's something that's being said over and over again, that consent is not an event, it's a process. It's not a one-time thing. And the lived experience of living with these digital tools may alter one's own preferences and perceptions. And the same goes not just for research studies, but for the real world and regular use of consumer products. We don't often pay much attention to terms of agreement for a lot of the software and hardware we sign up for. And oftentimes we don't know what we're signing up for or how we can get out of things that we've signed up for. But when we think about these digital health tools, I think it's an imperative that we create systems that allow the user to access their information, to have informed decisions about what they want to share, and to recognize that those preferences may change over time and may change a lot, or they may not change over time, but we need to have that flexibility embedded in the systems so that users have both control of what it is that they're collecting, as well as receiving feedback as to what is going on with their data and who has access with them. This complicates matters further when we think about solutions that are designed for people with cognitive impairment. We have quite a few projects in the literature you can see globally that look at smart homes for people with dementia. So in these cases, when we think about data access, the consenting process, privacy policies, it's usually not the patients themselves, but family members or people with power of attorney function who make the decisions on behalf of the patients. And here it is a complex ethical dilemma. How do you honor the participants' wishes and preferences while at the same time wanting to have information that could potentially keep them safe at home or at a specific residence? So the fact that we are looking at systems that are very data intensive allows us to get more and more information about the daily living of an individual, but at the same time, it opens up even more data collection streams that may or may not have been acceptable or desirable by the participant. So when we think about dementia care, smart homes are emerging as desirable tools, but I think we need to continue that discussion around the ethical implications to ensure that we've heard all the stakeholders' perspectives and come up with an ethical framework that honors the individual's privacy and autonomy to the extent that it does not compromise their safety and well-being. That is, in general, I think, something that becomes important with a lot of these digital tools, and that is that we need to put in the clinical, the ethical, and the legal considerations ahead of this deployment. A lot of times technology advances at such a fast rate that we try to catch up and have these considerations after the systems are already out there. But now that we see how they're becoming more and more part of our daily living, we have the opportunity to actually think about the right framework to integrate systems that are safe and at the same time are addressing issues of safety, security, obtrusiveness, and users' autonomy, and honor their values and preferences. So with that, I want to thank you for your attention. I'd be happy to answer any questions you may have, either now in our Q&A session, or here's my email if you have any follow-up questions after this talk. And again, thank you for your attention.
Thank you, George. That was fantastic. Let's, as we've opened it up now, and Aria, perhaps you could join us, let us know, let's take a look at the Q&A and see. Looks like we don't have anything in the Q&A right now. If anyone has questions, you can put something in there and we will see that. I have one, George, that perhaps you can get started with. One of the things that University of Minnesota is working on is translational studies. And so I wonder if you could address that sort of gap a bit. Maybe gap is probably not the right word, but that transition from looking at what is possible technologically to implementing what is practical and feasible and doable in the healthcare space, because it seems like just amazing things are going on, but I've also, in doing the kinds of interventions that you've talked about, but it's remarkably slow to be picked up. I shouldn't, maybe it isn't, maybe I'm just not aware, but it's challenging to get it picked up and widely used because of a number of the limitations that you talk about. But I'm just wondering if you could say a little more about that transitional space or translational space and what's needed there and what are the key factors driving that translation?
Yeah, I think that's a great question, and I'll answer it with a little bit of a bias because I have the researcher's perspective, and we often worry about the work we do in an academic setting and how that will translate into the real world. I think part of the challenge has to also do with the way we conduct our research studies and the funding we receive. That is sometimes siloed, and we don't yet, although we're getting better at that, have those translation considerations early on in the conceptualizing of the study. So oftentimes we'll have a great idea about a new system and we'll focus on, does it even work? So let's do a feasibility study. Okay, now we did a pilot study with 5 or 10 people, and they seem to really enjoy this digital tool. We found some information about how to improve it and refine it. Now let's do a study with 20 people. In this study, we found great, people might like it. And now let's see if we'll get funding for more, which is great and is a way of traditionally conducting the studies. The problem with that is that at one point you just stop, maybe funding was no longer available or you got mixed findings. And it is more important, and I think there is now a slow recognition of this, that the translation considerations should be taking place much earlier than at the very last stage when you deploy this in a large number of homes, and I think should become part of the early design specifications. The reason why we think participatory design is important and it's becoming more and more accepted as the way to design these digital tools is not only because you empower people to sit at the table and give you their perspective, but ultimately, if you want to know if a digital tool is going to ultimately become used and part of people's lives, you have to have the patients and the clinicians at the table when you design that system to identify what the problems or the challenges may be. And also have policymakers and administrators at the table, because we can come up with great systems, but it turns out there's never going to be any type of reimbursement for it, let's say. So those considerations need to happen early, and there is a little bit of somewhat conflicting viewpoint of, oh, first we need to do this as a siloed feasibility study and then we move on, and there's a certain life cycle that isn't really aligned with the real world needs. I think more and more we see translation becoming a consideration that is addressed earlier on. We have, I think, seen some improvement in terms of also interdisciplinary work, so that when we don't have people in the technology space creating solutions and then hoping to find a problem for the solution, and then somebody trying to adapt that software or hardware. And now we see more synergy, but I think there's definitely a lot of room for improvement. Another thing that I think will help with translation has to do with more pragmatic trials. So a lot of times we design these research studies where you deploy a digital tool in ideal controlled circumstances, and it takes so long to obtain the funding and then do the study, collect the data, that by the time you have your findings, the technology has already been outdated. There's by now, new and better and smaller and faster processors. And so that also is not perhaps how we want to be examining the use of digital tools. We want to test them in real world conditions, but also recognize we need to have some flexibility as to how these systems would also evolve. In an ideal research study, the unit of your observation stays the same. You can't tweak it, you can't change it. But in the real world, things do change and evolve much faster. We see even with wearables, some colleagues had started a wearable study. By the time they were ready to start collecting data, there was a new Apple Watch that was kind of taking care of all the things that they were hoping to measure. So it is, I think, something where we need to be more pragmatic in the design of our studies. And like I said, going back to your question, thinking about implementation, not as or translation, not as an afterthought, but actually at the very beginning of conceptualizing the whole product, the system, and the study.
Well, and with that last little comment, you point to the fact that I think we're all aware, or increasingly aware, that a lot of this translational work is front and center for technology development companies or organizations that are, traditionally intensely involved in technology, and they're seeing the healthcare space as a new potential space for technology development, and just sort of bypassing the existing healthcare system, the existing research system, and saying we're just gonna go straight to the consumer with it. And we've got our own scientists, we've got our own engineers. We'll just figure out a way that it works as a consumer product rather than as a system to be deployed in a health system somewhere. And I think that's a dynamic that the healthcare system possibly hasn't had to address quite so much in the past. There's a question that just went into the chat, and I'm going to go ahead and read it to you, George. I was curious about reimbursement. Have the tools only been implemented by a research, or have they been scaled and used as part of a healthcare intervention? I'll let you respond, and I have some things to say about that as well, but go ahead, George.
Yeah, so some of especially when talking about smart home tools specifically, they have been used and tested as part of intervention. So in addition to the smart home types of sensors I showed you, there's commercially available solutions where you can buy a set of sensors and it works on a subscription model. And they have been tested in long-term care facilities or independent retirement communities. So there are systems that have been deployed, similar to what you were saying, directly from the vendor in partnership with the clinical side, not necessarily as a product of research. It's just the vendor, the hardware vendor worked with a network of retirement communities, for example, and they've deployed their sensor solution. So yes, a lot of these tools are implemented and have been scaled. And I think one of the challenges sometimes with this model is that it's easier to show some benefits or outcomes with one's own research, but then how easy is it to generalize to other settings? You know, there's sometimes gaps there in the translation of the evidence. But there's definitely a lot of those digital tools that are not only commercially available, but have been tested outside of academic research in partnership with clinical sites. And there's even smart home solutions. We have several on the East Coast where you can, as a family member of a loved one who lives alone, subscribe directly. It's direct to consumer. So you don't even need to be member of a retirement community or part of a health related organization. You as a consumer can directly subscribe to the vendor and purchase the monitoring solution, the software, the hardware, and the monthly fee. They're definitely available and have been tested. What would be ideal, which I think we don't have, is a combination of doing that and having a solid evidence base based on rigorous research. That way we could have both the real world implications as well as the solid evidence as to what works and what doesn't work. And I feel that we're not there yet, especially with some of the tools I talked about today.
Yeah, I agree. And I would say too that where I've come across it in its most advanced form is either, as you say, like a subscription direct to consumer model. I understand that there are a number of retirement community type settings that have deployed it on a larger scale, like you say, and they use it as sort of as a value add, have your, move in here and we will, keep track and intervene. And in fact, there are, as you probably know, there are retirement communities that include your Medicare Advantage plan as well as your rent and your, it's a kind of a whole package. And so they're motivated there. They have a financial motivation and there's value that they're creating with the tools. What I wonder, and I'm hoping to see more of, is as we do more chronic disease management in the traditional healthcare setting, that a bridge will start to open up there to, producing value using these sort of tools. I mean, in the home health setting, you have kind of the person's value in that they want to stay healthier, or the family value when they want to stay healthier. But reducing healthcare costs is also a potential value. And so there are drivers there, but we're not quite linked up to them yet. And in fact, you have to pay your own way to reduce your medical costs. And it would be great to see payers and health systems have a way to say, if you've got a smart home, or if you've got this technology available and you can register it, kind of like we did with gym memberships back in the wellness plans, we'll reduce your premium, or we'll, subsidize that as a way of, because we recognize that that's going to reduce your overall cost.
Yeah, absolutely. And I wanted to add to that there is now more consumer awareness. So we hear a lot from administrators who say that it's now family members who say, I want my loved one to come to your facility, but what types of technologies do you have to keep them safe? So there's now more increased awareness from the public that there could be potentially those digital tools. Whether they work or not, I think it's something that still family members in some cases value and appreciate as an extra service that the facility has to offer.
Right. Well, this is really fantastic, George. I want to thank you once again for agreeing to come and share your wealth of knowledge with us, and look forward to hearing from you again at our conference May 24 and 25 in Minneapolis. That is bound to be a stimulating conversation as well. And with that, I guess we will turn it back to you, Arya, to close this out.
Thank you, Jonathan. Just a reminder that our next webinar will be held on Thursday, April 21st. It will focus on innovation and integration of telehealth into population health, and it will be hosted by the Northeast Telehealth Resource Center. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Dr. Demiris for his presentation today, and to the Great Plains Telehealth Resource and Assistance Center for hosting today's webinar. Have a great day, everyone.